There we go. Well, thank you very much for that introduction. It's very kind of you. And also good day to the other participants and viewers. I have no disclosures to make or conflicts of interest to list. I'm going to talk most specifically about immunohistochemistry and my belief that cell blocks are actually the optimal substrate for the majority of work we do with immunohistochemistry, and also for techniques like fluorescence in situ hybridization. And as we'll see, to a certain extent, I think cell blocks are actually a great material to keep substances available for things like next generation sequencing. And I usually believe that it's very helpful to do rapid on-site evaluation so that you can actually triage your material optimally. Clearly, if you think something's a lymphoma, cell blocks are probably not the optimal way to go. You can put it into RPMI and send it for flow cytometry. However, for the vast majority of other lesions that you're considering a differential diagnosis in, the preparation of formalin-fixed, paraffin-embedded cell block material, I think, is optimal, and I'll review some of the reasoning behind that statement. Now, immunohistochemistry is now really the standard of care in many clinical situations for the workup, diagnostically and prognostically, for a wide variety of lesions. Immunohistochemistry is a very, very well-known technique with which we have decades of experience. With what the fixation protocols are, how specimens should be prepared, and we all have large libraries of positive controls that we can use to ensure that our staining is appropriate and specific. Immunohistochemistry is used for a wide variety of questions, things we need to answer. The first and foremost is, of course, diagnosis. And in this, we're using various antibodies to determine direction of differentiation. That direction of differentiation helps us determine whether it's a lymphoma, a melanoma, a sarcoma, carcinoma, etc. But today, that's only the start of the questions we receive from our clinical colleagues, because even when we say that this is an adenocarcinoma, generally they want to know a more specific subtype, and usually the primary site of origin. In other words, they want to know that it's an adenocarcinoma from the lung or an adenocarcinoma from the gastrointestinal tract. And by using immunohistochemistry and subsequently immunocytochemistry, we can, in most cases, come to a very specific type of malignancy present, organ of origin, and then even in that, usually the subtype. Not only are we expected to make a rather definitive and clear-cut diagnosis, but we are also being asked very frequently to predict prognosis. And we have a number of markers that are useful for prediction of prognosis. Ki-67, probably the one that's used most frequently today, and of course that comes into play very often for neuroendocrine tumors at a variety of sites, be it lung, pancreas, etc. And then finally, the area that we're seeing really increasing utilization of immunohistochemistry is the prediction of response to various therapeutic agents. The rise of so-called personalized medicine or targeted therapy has really put a lot of pressure on pathologists to be able to run either molecular typing for mutations that are predictive of response to very specific therapies, or more broadly to predict response to classic agents such as estrogen receptor, progesterone receptor, and HER2/neu. So we are now required standard of care on certainly histologic specimens, and as we'll see more and more on cytologic specimens, to be able to go the extra mile and give very specific information on whether a patient is a candidate for certain types of targeted therapies. Now, immunohistochemical methods are very well standardized for histologic preparations, meaning formalin-fixed, paraffin-embedded materials. We also have large libraries of controls so that we know that our staining protocol actually worked for that particular antigen. We know methodologically temperatures, we know antibody processing requirements, we know dilutions very, very well for formalin-fixed paraffin-embedded material. And for markers like estrogen and progesterone receptors, we know and are required to meet standardized fixation lengths that CAP has dictated for our results to be acceptable. So immunohistochemistry is very, very well standardized. Of course, cytopathologists are now having to address many of the same needs, very specifically for diagnosis, prognostication, and for prediction of response to therapy. The expectations for an FNA specimen are today essentially identical as they are for a core needle biopsy specimen, and therefore we have to meet those expectations with our cytology diagnoses. It's important to understand, as I think has already been well illustrated, that technically immunohistochemistry is not identical to immunocytochemistry, although we can get close to that similarity if we use a formalin-fixed paraffin-embedded cell blocks. Most antibodies have been optimized for formalin-fixed paraffin-embedded material. And that actually is very helpful and pushes us strongly to the use of formalin-fixed cell block material. Now, as has become obvious in the past decade, cytology has become the predominant method for the additional diagnosis of lesions at a variety of body sites. These include the lung, pancreas, thyroid, and also metastatic deposits in lymph nodes or masses, say, within the abdomen. So cytology is very, very important for initial diagnosis. Often the cytology specimen is indeed the only material available for testing for prognostic and predictive markers, so that initial cytology, that initial FNA specimen is immensely valuable, and we have to treat it carefully that it is presented in such a way that we can get as much information from it as possible. Now, just to look at ancillary testing being performed on cell block specimens, how it's grown over the years. This basically shows its growth at Missouri from the time I arrived to the present, or to 2018. And you can see in 2014, the percentage of cases that had cell blocks that were used for ancillary testing was essentially negligible. Over the next 4-5 years, it went up dramatically, went from much less than 1% to 3%. And if you were to look at how we use it today in 2020, you'd find probably a tenfold increase in the utilization of cell block material for immunocytochemistry. So it's a very, very important source of material for answering those issues that clinicians need information on. Now, immunocytochemically detected antigens may have different cell locations and patterns of staining in or on the cells. Specifically, there are certain antigens that are cytoplasmic membrane bound, Therefore you need to look in that area for the specific information as to whether it's positive or negative. Examples of cytoplasmic membrane-bound antigens are, of course, HER2/neu and PDL1. Staining elsewhere in the cell is not going to give you accurate information. It's only a cytoplasmic membrane staining that you should evaluate its presence or absence. Similarly, certain antigens occur within the cytoplasm. The keratins are a good example of this, but also chromogranin and S100 protein are cytoplasmic antigens. So don't look for nuclear staining as helpful. It's really just the staining that's in the cytoplasm that's useful for interpretation. And then finally, there are some antigens that are exclusively nuclear. STAT6, the antigens associated with microsatellite instability, estrogen receptor, and the progesterone receptor. These are nuclear located antigens, and cytoplasmic staining or membranous staining are not helpful in interpretation, and they are often difficult to lead to complexities of interpretation. At any rate, just some clarifications of how different antigens are localized within the cell. This is an example of a PDL1, an increasingly important predictive antigen, and you can see in this nice example from a cell block, it is really purely a membranous cytoplasmic membrane antigen, and that's what you're evaluating for percentage of cell staining. Keratins shown here. This is clearly a cytoplasmic antigen. The nuclei are non-reactive as you would expect, and it's a nice clean background, so we know the staining here is genuine and useful for interpretation in diagnosis. Finally, antigens like TTF1, estrogen receptor, progesterone receptor are staining nuclear antigens. You should have nice, robust, and specific staining within the nucleus. You don't want to have background or cytoplasmic staining. This is what you want to see in your cell block material. Now, as we've heard, cytology specimens may be prepared in a variety of ways. Some are very useful for immunocytochemistry. Some have significant drawbacks to them. For fine needle aspiration people like myself, initially the predominant specimen type are smears. I preferred air-dried Difquick or Romanovsky stain material, especially when I'm doing rapid on-site evaluation, and a lot of my material goes to smears. But the minute I feel that they are in the lesion and I can recognize a difficult differential diagnosis, I will get additional material for cell block preparations. Cytospins were an old traditional way of getting a concentration of material onto your glass slide. They have some advantages, but as we'll see, they certainly have disadvantages for immunocytochemistry. That's also true of other liquid-based preparation methods, which are becoming increasingly used at a variety of body sites, including thyroid, but also for pancreas and pulmonary specimens. Filter preparations rarely used today. Certainly, I don't use them for FNA material or for things like peritoneal or pleural fluids. They have traditionally been used for CSF fluid, and some institutions still utilize them for that, but I think that certainly they are being de-emphasized for a variety of technical reasons, and at times they are hard to interpret. And then finally, cell block material, which is what I am increasingly relying on for difficult differentials and diagnosis, as we'll see, but also for predictive and prognostic markers, because our antibodies are, as I said, optimized for formalin fixed paraffin embedded material, and that's what you can get with cell blocks. Now, unlike histologic specimens, there is unfortunately less standardization for cytology specimens, particularly the non-cell block ones. We in general have had less experience with them, and therefore there's more variability from laboratory to laboratory on how we use immunocytochemistry on smears and cytospins, other liquid-based preparations. Now, each specimen type is associated with a set of technical issues and challenges that need to be addressed. And some of the major issues with immunocytochemistry are that there's variability in fixation methods. Clearly, some specimens are alcohol fixed, some specimens are formalin fixed, some are simply air dried and processed. All of these will have an impact on the results and outcome of our immunocytochemistry studies. With some of the preparation techniques, particularly smears, but also cytospins and liquid-based preparations, you can get quite a bit of cell overlap and cell crowding, which may lead to artifactual staining or specimens that are relatively hard to interpret for what actually is reacting where. In smears and cytospins, liquid-based preparations, many of the cells are single cells, and therefore there may be edge artifact because of very small groups or individual cells. And indeed, isolated cells, they're all edge in reality, so you can get false positive staining or at least artifacts that may be difficult to interpret when you're doing immunocytochemical staining. The presence of abundant proteinaceous fluid or necrotic debris in the background can be a problem. This is particularly a problem in smears, but also is seen in some of the liquid-based preparations. And then finally, there are issues of antibody penetration into whole intact cells. This may reduce cytoplasmic staining or nuclear staining, or may require a prolonged incubation period. Remember, when we look at surgical pathology material and cell block material, we're cutting sections through those intact cells, so they're no longer really intact. We've opened up the cytoplasm and the nucleus for easier penetration of the antibody. When we're using smears and other preparations that retain whole cells, that penetration may be delayed or inhibited. And then finally, I think one of the major problems with the other types of specimens other than cell block is that we may not have appropriate control material for the antigen or that specimen type. Obviously, optimally, you want to have a control for that antibody that's of the same specimen type. That's easily doable for cell block material as formalin fixed paraffin embedded because we just use our surgical pathology archives. But what's the appropriate control for a smear? It may not be actually formalin fixed paraffin embedded material, and honestly, we just don't have thousands of smears available for all variety of the hundreds of antigens we can do. So that lack of an appropriate library for different types of cytology preparations is, in my mind at least, somewhat of a problem for QA. Now, fixatives do vary with preparation methods. Fixatives can be formalin, 10% neutral buffer formalin. It can be ethanol, methanol, other fixatives are available. Now, the fixative may impact, and frankly, in many cases, does impact staining characteristics. It may have impact on antibody avidity. It may impact specificity and sensitivity, and these are important issues when we come to interpret the stained cytologic preparation. One example that I saw years ago was that avid and biotin staining for immunohistochemistry or cytochemistry can lead to problems. I think much of this has been reduced by newer protocols, but I distinctly remember a FNA of the thyroid that was a smear preparation. Um, the differential diagnosis was uh, some sort of hyperplasia versus actually medullary carcinoma. The senior surgical pathologist, or cytologist rather, felt strongly that this was going to be a uh, medullary carcinoma. They ordered a calcitonin to confirm that diagnosis, and indeed the large cells with abundant granular purine cytoplasm stained strongly with an avid and biotin based immunocytochemistry preparation. Uh, that led the patient to have a total thyroidectomy, and unfortunately when the thyroid was examined histologically, it was a hyperplastic nodule that had a predominance of Hürthle cells in it. And indeed, oncocytic neoplasms, Hürthle cell neoplasms in the thyroid are known to react in a non-specific manner when avid and biotin staining is used. So it can lead to false positives if you don't understand the uh, limitations or characteristics of your stain, and therefore for cytology preparations, that's one reason to use cell blocks, where we know the technique very, very well from our surgical pathology experience. Now, preparation type may impact the strength of staining of different portions of the cell. Uh, Smears and liquid-based preparations contain whole cells. Cytoplasmic and nuclear antigens stain more poorly in many cases, since the penetration of the cells may be delayed or poorer. This can lead to false negative diagnoses, or it can lead, when you're quantitating the amount of staining, or qualitative an assessment, such as for estrogen receptors, progesterone receptors, you may underestimate the strength of the staining. So if you say it's weak, moderate, or strong, simply by the staining technique and the preparation you have, you may underestimate the strength of the stain, and that can have implications, at least in some treatment protocols, as to how likely they will receive tamoxifen or another drug. Cell membrane antigens often stain more strongly with whole cells because those are very well presented, and you are indeed able to stain the entire cytoplasmic membrane. Now, incubation times appear to differ with preparation type. They may need to be longer when whole cells are used, such as in cytospins and smear preparations. Now, while most antibodies are optimized for formalin fixation, they may actually, in some cases, react more strongly with alcohol fixation, and so you need to take that into consideration when interpreting a specimen undergoing immunocytochemical staining. Background staining can be a problem with cytospin and liquid-based preparations. In a single study referenced at the bottom of this slide, 66% of cytospin in thin prep specimens demonstrated high background staining in comparison to cell block specimens, and this certainly can complicate how we interpret results. Now, highly important technical variables for immunocytochemical staining are, of course, fixation protocol and fixative, as I've already alluded to. Fixation protocols impact antibody specificity and sensitivity. Target antigen and antibody clone impact the quality of the staining for cytologic specimens, so you need to have experience with the antibody clone you're using. Now, adequate controls for specific for specific antigens being tested are necessary for good quality assurance. Controls should be antigen and specimen type specific for optimal quality control, but most laboratories, they have large libraries for formalin-fixed paraffin-embedded controls for the antigens being tested based on that paraffin-fixed material. Appropriate antigen libraries are much more limited for smear and liquid-based preparations and cytospins, making availability of appropriate controls much more restricted. Now, considering all the technical assessment issues, I believe that cell block preparations appear to be the best substrate for immunocytochemistry. It's important to remember that success of cell block techniques depend on the aspirator's skill in obtaining an abundantly cellular specimen, as well as in many cases obtaining tissue fragments, because that's very helpful, as I think we'll learn in the next talk, that tissue fragments with a stromal neoplasm interrelationships can be very, very helpful in assessment. Now, since many predictive markers require a minimum number of cells to be counted, cell block cellularity is indeed very important. And it's known that type of fixative does impact cell block cellularity. In a study I did a few years ago, formalin fixation consistently produced cell blocks of higher cellularity than did cytolite fixation. And so in my laboratory, we use only formalin fixation for the preparation of cell block specimens. Just a short rundown on the advantages and disadvantages of cytologic preparations. Air-dried smears, they're quite a common specimen, especially if you use rows. It allows interprocedural interpretation. It has pretty good sensitivity for immunocytochemistry. It does have some disadvantages. They're prone to artifacts due to cell distribution and overlapping cell crowding. You can get non-specific staining. When you're using air-dried preparations that requires rehydration and alcohol fixation. Again, we lack appropriate controls for many antigens in these types of specimens, if not all of the smears. When you have alcohol fixed smears, again, is a common specimen type. The disadvantages are pretty much the same because of cell distribution and overlapping and crowding. Again, we lack appropriate controls for many antibodies. Filter preparations, highly sensitive for the antigens in many cases, but again, lack appropriate controls. This is a type of specimen that's disappearing and it has some background issues associated with it. Thin preps, they have good ICC sensitivity for many antibodies, and you can make replicate specimens. You just, in a smear, you just have one go at it, but with thin prep, you can make replicate specimens. But again, high background may be a problem, and the control issue is also a problem. Similarly with cytospins, I think the problems are identical with high background. You may have membrane staining that's difficult to interpret with cytospins. And then finally, cell block. The immunocytochemical staining characteristics closely resemble or are identical to formalin-fixed paraffin-embedded surgical specimens, and you have a wide variety of control specimens that are good for both the antigen being tested for as well as the specimen type. It is less sensitive for many antibodies than smear or liquid-based preparations because in many cases, alcohol fixation causes an increased reactivity with the antibody, but this is not a problem to overcome because we're very, very used to using paraffin-embedded formalin-fixed material. Now, cell block immunohistochemistry, let's look at it for diagnosis. What we're doing here is really determining direction of differentiation for poorly differentiated malignancies, or even if you know, say it's an adenocarcinoma, almost invariably I will be asked, well, what organ is it from? And cell block immunocytochemistry can help us with that. I usually use for very, very poorly differentiated malignancies that at the time of Rose, I have no idea really precisely what they are. I will use an initial panel for leukocyte common antigen cytokeratins, melanin A, S100 protein, often vimentin, and if it looks to be a round cell malignancy, I add CD99. When the LCA leukocyte common antigen is positive, I submit it for a lymphoma workup. We have a hematopathology group, and it becomes their problem, fortunately not mine. Now, if the malignant cells are AE1, AE3 positive, I will then triage those to do just differential cytokeratins, CK7 and CK20. Depending on the staining pattern for those, I will go on to further panels that help determine a more precise diagnosis. For lesions that are CK7 or CK20 combinations, we can do further typing panels. CK7, CK20 positive. These are the most common neoplasms that do that. Urothelial carcinomas, pancreatic carcinomas, ovarian mucinous carcinomas. A follow-up panel is pretty easy to do on those in a step-by-step fashion so that we're not guessing and wasting material. You can use GATA3 for urothelial malignancies or uroplaque, and I like GATA3 better. I get better staining. CA125 for the ovarian lesions, and then a CA19-9 and MUC5 are helpful for pancreas. If I have a poorly differentiated malignancy or carcinoma that is clearly CK7 positive but CK20 negative, this is the biggest differential diagnosis. You can see what they fall out to be: non-small cell lung cancer, small cell lung carcinoma, memory carcinoma, non-mucinous ovarian carcinoma, endometrial carcinoma, mesothelioma, and squamous cell carcinoma of the cervix. A panel that's useful in following up those for much more specific diagnoses. The one I like is TTF1, that's for lung. GATA3 would be for breast. CA125, again, for ovary. Calretinin would be good for mesothelioma. We can use a secondary panel if I don't get convincing results for that, as shown on the right-hand side, and that may often help clarify what we're looking at. Just a schematic here. You can see the very poorly differentiated cells. The only markers that were positive were the keratins. Then I did my differential cytokeratins. CK20 was negative, CK7 was positive. So there's this tertiary panel, and indeed in this particular case, the cells were TTF1 positive. It was a pulmonary adenocarcinoma, and then I could refer it, if necessary, to molecular typing. Now, if we have a CK7 negative, CK20 positive, the most common cancer by far is colorectal adenocarcinoma. A panel that helps confirm that is CDX2 and MUC2, and if they're positive, that gives you a good indication that you have a gastrointestinal primary, colorectal primary. Now, when you have CK7 negative, CK20 negative, these can be squamous cell carcinomas of the lung, prostatic adenocarcinomas, renal cell carcinomas, hepatocellular carcinoma, adenocarcinoma. That's your differential diagnosis. The panel that's helpful: prostatic specific antigen, prostate obviously, RCC CD10 for renal cell carcinomas, HEPAR1 for the hepatocellular carcinoma. Inhibin is helpful for those rare cancers of the adrenal gland. Now, if we are negative for all of the markers I showed, except perhaps for vimentin, I usually come to the conclusion that I'm really working up a sarcoma. At least that's in the vast majority of cases, and these are antigens that can be used: smooth muscle actin, other muscle markers, S100 protein. If it's an intra-abdominal lesion, I will add CD117 for gastrointestinal stromal tumors. DOG1, also very, very useful. If it's a low-grade spindle cell neoplasms, CD34 STAT6 for your solitary fibrous tumors can be very, very helpful. Now, follow-up panel for soft tissue sarcomas. This is another possible set that can be used. I usually use the first one I showed you as my initial work, but this one will also be helpful in many, many cases. Now, if you really have a sarcoma, I think there's been some major advances in the last 5 or more years that we have found for sarcomas, much more so than carcinomas, very specific mutations that are associated with sarcoma types. And there are now a variety of next generation sequencing panels that contain large sets of these mutations that help you come to, in many cases, a very definitive diagnosis for sarcomas. That certainly works for solitary fibrous tumors, for synovial sarcomas, and even things as simple as GNAS mutations in myxomas. So these next generation sequencing profiles can be very, very helpful for the diagnosis of soft tissue neoplasms. Let's look briefly at prognostic markers. Ki67 is probably the one that I use most today. Cell block specimens are very good specimen types for assessment of many of the prognostic markers that are used. HER2/neu has some prognostic accuracy in predicting how patients will do with low-grade node-negative carcinomas. ER and PR also have some prognostic significance, although they tend not to be used for that today. Important issue for prognostic markers is, of course, the number of cells that are needed to be evaluated, and this has been worked out fairly significantly for some of our markers, particularly Ki67. So there is a minimum number of cells that have to be counted for an accurate acceptable result. And the number of cells which need to be evaluated varies with the marker. For HER2/neu, if you're using FISH, you need to evaluate a minimum of 40 cells. Ki67 for pancreatic neuroendocrine markers, you need to evaluate at least 500 cells. And for Ki67 evaluation for lung neuroendocrine markers, carcinoid tumors, atypical carcinoid tumors, etc., they want you to count a minimum of 1,000 cells as the references show. Now, because of the limited number of cells in some cell block preparations, the minimum number of cells analyzed may not be met, so our results may not be as acceptable as we would like. Here's an example for Ki67. Clearly, we have more than enough cells, and we're well above the cut points. This is something that, if you counted it up, would have enough cells to get into the neuroendocrine carcinoma variety. But if we showed a scanty cellular specimen with only one or no cell staining, then our results may not be accurate. Let's move on to predictive markers, shown here. PDL1 microsatellite instability markers can be done by immunohistochemistry. There's 4 important markers, as we'll see. Estrogen receptor and progesterone receptor, do we or do we not use tamoxifen? And then, of course, HER2/neu can be done by immunohistochemistry or FISH. Both can be done easily on formalin-fixed paraffin-embedded material. PDL1, just again to reiterate how it stains, I'm only interested in evaluating the cancer cells, their cytoplasmic membranes, and the immune cells in the background as to whether they are staining or not. And there are calculations that you make determining whether it's a non-expressor, low or high expressor. Now, the use of cell blocks aids in establishing the location of the positive cells in relation to other cells, and this is very, very useful in evaluating markers like PDL1. And therefore, the relationship of the immune cells with the neoplastic cells is very much utilized in evaluation of some of the schemes for PDL1 prognostication or prediction of response. Let's look at some case examples here. Large nasal mass. The patient had epistaxis, but was otherwise healthy, had no prior history of any neoplasm at all, and MR and CT examinations revealed nothing but a nasal mass. An FNA was obtained, cell block was made, and you can see that indeed it's a poorly differentiated lesion. It's not clear exactly what the direction of differentiation is just from H&E evaluation. So what was then done was the first panel of markers was performed, and it was indeed found that both S100 protein and CD99 were positive. It's known that CD99 is positive in melanomas, and certainly S100 protein is positive in melanomas. So at that point, a secondary panel was utilized of AE103 and SOX10. They were both positive, and a definitive diagnosis of melanoma was made. And indeed, the patient had a primary melanoma of the nasal sinus. Just to show you how the antibodies worked on the cell block material, we can see S100 protein nice and specifically staining in the cytoplasm. SOX staining was purely nuclear, very easy to interpret, and therefore we had two very good stains that led to the diagnosis of malignant melanoma. Let's take another one, soft tissue mass, left arm. In a middle-aged person, we can see that we have a small fragment here in this cell block. It is clearly a spindle cell lesion that brings in the differential diagnosis of spindle cell neoplasms. Slightly higher power view shows that the nuclei are fairly bland. There's no mitotic figures here, although you wouldn't expect to see them in actuality in specimens that small. So let's use that spindle cell neoplasm panel. Smooth muscle, actin, desmin, S100 protein, CD117, all negative. STAT6 was positive. And therefore, the preliminary diagnosis based on this was that we were looking at a solitary fibrous tumor. While STAT6 is quite specific for solitary fibrous tumor, the specificity is not 100%, and usually I confirm those by molecular diagnostics, and that was performed on the cell block material. It was indeed positive. Again, just to show you how nice and clean that STAT6 nuclear staining was in that soft tissue mass of the arm. Now, a more common question I run into is a pulmonary nodule, maybe single, sometimes it's multiple. This was a single pulmonary nodule. The clinicians favored, or the radiologists favored, that this was a pulmonary primary. We can look at it on the cell block material, and it's quite clear it's a non-small cell carcinoma of some type. I would favor a adenocarcinoma on this morphology, but in general, to allay the fears of my clinical colleagues, I will perform a very limited immunohistochemical panel so that they can put their little check in their checkbox schemes for their treatment panels. And indeed, I did TTF1 and P40. P40 was negative as expected. TTF1 was positive. A diagnosis of pulmonary adenocarcinoma was made. The patient turned out to be high stage, and therefore it was referred to molecular testing of the cell block material for EGFR, ELK1, and ROS1 testing. It could have been sent for next generation sequencing. In many institutions it would have been. Just to show you how that staining pattern went, clearly with cytokeratin positive, nice, strong, specific TTF1 positivity. This was pulmonary adenocarcinoma. And then there was a patient with multiple pulmonary nodules. The radiologist said that they thought that it could well be a metastasis or multiple metastases, although at the time the clinicians did not know of any prior history, and therefore the history we were given was that this that there was no prior neoplastic disease present. So it came to us somewhat of a unknown, although just as we were working up, they said, well, there might have been a history of colon cancer. So clearly from that material, we thought it was a non-small cell carcinoma. We did our normal staining pattern, TTF1, P40, but because of the potential for a metastasis, we added CDX2 and PAX8 RCC. TTF1, P40 were negative, as was PAX8 and renal cell carcinoma antigen. But CDX2 was strongly positive. This led to a diagnosis of a GI primary consistent with a colorectal primary that fit with the history that subsequently became available. And indeed, the patient had a undisclosed history of a adenocarcinoma of the colon. Now, the development of targeted therapies and more complex classification schemes put forward so that the oncologist can use very specific therapies rather than more general chemotherapy approaches has really put more emphasis on the pathologist giving much more specific information than we had to say a decade ago. And this information is very, very necessary for targeted therapy, adequate therapy in today's environment. Now, the increased reliance on marker studies has placed greater emphasis on the need to conserve sample material so that we have material for prognostic, but most importantly for predictive testing, whether that be molecular or immunohistochemistry, so that that information can be passed on to the clinician. And indeed, we are being I'll say encouraged, you might put in quotations, forced to get more and more information from smaller and smaller volume samples. And therefore, the sample we get, we have to be very careful not to waste any of it in a excessively complex and random diagnostic testing. So we want to do very focused testing, and that's where those panels I showed you can come into great utility because they do actually limit the amount of tissue being used rather than something more random. Now, clearly, if you have a very specific idea from the cytomorphology, those panels aren't necessary. You just order the few immunohistochemical stains that confirm your H&E diagnostic impression, but it's very important to keep as much tissue as humanly possible so that you can run predictive markers. Let's just use an example of lung, because for me, this is where it comes up the most. You have a pulmonary nodule, and you use some for diagnostic testing. You recognize that this is a rather poorly differentiated non-small cell carcinoma. By history and imaging, it really is thought to be a primary. So you can use a very limited testing, really restricted to TTF1 and P40. If you have some doubts about the results you get, you can add things like napsin. But I think in the vast majority of cases, TTF1 and P40 will give you the answer. So let's just summarize my feelings about immunocytochemistry and the use of cell blocks for it, and why I believe it's the cell blocks are the optimal technique. I think there's a number of technical issues that push me towards using cell blocks whenever I can for immunocytochemistry. Immunocytochemistry is valuable for not only diagnosis, but also for prediction of behavior and prediction of response to targeted therapies. The latter is becoming increasingly important. Immunocytochemical panels, as I've shown you, when you have a very, very poorly differentiated malignancy and you really from the morphology alone are not sure what you're dealing with, those panels in a stepwise fashion can get you to a very, very specific diagnosis. Not only that it's an adenocarcinoma, but it's an adenocarcinoma of the colon or the kidney, etc. Now, the use of predictive markers may be limited in cell block material because of minimum cellularity requirements. You need to have, for neuroendocrine markers, a minimum of 500 or 1,000 cells. And then finally, triage of material for optimal specimen assessment is necessary due to the small size of samples we usually get from cytology techniques. And with that, I will open it up for questions, and thank you for your attention.